So we're 1 minute past the hour. I do want to start on time, and I'll see a few more people join as I go through our housekeeping items. So thank you everyone for joining this month's Ask the Expert webinar. I'm very excited to have two amazing people on our panel and an amazing moderator, Monique Rasband, who's the Vice President of Imaging Informatics and Oncology with KLAS Research. Before I hand it over to Monique, my name is Ariella Shoham. I'm Aidoc's Vice President of Marketing. I will be your moderator. You are all on mute, but I will be following any questions that you have. There is a Q&A option on Zoom. I guess I don't have to explain Zoom as much as I had to in the past. But for those of you who are unfamiliar with this platform, there are interaction icons either at the top of your screen or the bottom of your screen. You can select the chat or the QA button, and then you can submit your questions. I will probably wait until the end of this session. We're looking at about between 35 and 45 minutes of a session, and then we'll leave 10 to 15 minutes at the end for open questions. And so without further ado, I'm going to stop sharing my screen and hand it over to you, Monique, to run this panel and introduce our great panelists. Thank you, and have a great webinar.
Excellent. Thank you so much. And thank you for everyone who is joining. I know we're representing a lot of different time zones here. So for some of you, it probably feels like a great time. For other of you, a bit late. So thank you so much for being accommodating on the time. Also, of course, want to thank everyone that put this together. I know a lot of work and time goes into it. And of course, would like to thank the panelists and introduce, they're really the stars of the show. So want to get to that right away. First of all, want to introduce Dr. Max Rosen, and he is the chair of radiology at UMass. Probably a lot of you have seen him or heard him in different venues or hear him speak. So I was really excited to be a part of this today. Also want to introduce Dr. Samir Shah, and we had a great time catching up. So I was not familiar with Dr. Shah. I'd seen his name, heard of him, and we got on the phone, and it was funny, our two paths and lives have crossed in different areas. So we had a great time catching up. So he is the Vice President of Clinical Operations for Radiology Partners. So I was also excited when I talked to the panelists offline, prepping for our presentation today. Both of them have a different background in the way they're utilizing. There are some great crossovers, also a lot of fun things that I hope you learn from them that you could apply in your different practices or different settings. So without that, we'll go ahead and get started. Just a couple of things that I wanted to share with you from our research. And it's taking just a minute to load. If you guys don't mind letting me know once you can see that. It says it's taking a moment to load on my end.
I'll let you know.
We just practiced this, and of course it went really well.
Murphy's Law.
You right?
We can see, Monique.
Okay, perfect. So I apologize for the delay. So you can see the screen okay?
Yeah, we can see it.
Okay, perfect. So just a couple things that I wanted to point out. When we were working on our report, our AI and imaging report, this was actually a repeat report for us. So most of this information was gathered throughout 2019, and we published early 2020. We did actually have a report prior in 2018. So just wanted to set that up. This was not performance, it was perception. For those of you who are not familiar with KLAS, I think it's helpful to understand where do we get this information, where do we get the data, and just know and understand that our mission is to improve the delivery of healthcare technology. Also, it always goes back that we are dedicated to the healthcare provider. And so all of our information comes from providers that are in a variety of roles. So we like to know what the clinicians are thinking, of course, from the IT side, and understanding what's behind the decisions. So you will definitely see a few of the data coming out in what I show you, but also in some of the questioning. I think it's helpful to understand why we have looked at it the way we are. And then of course, just to focus on the customer experience. And then just so you understand all of our data, 90% of it is actual live interviews. So it's not something that is a survey monkey. We get on the phone. So hopefully some of you on the call have actually talked to us and experienced that, but thought it would be helpful for you to know that the individuals that we talked to were actually in interview. So I thought it was interesting. In 2018, we had a lot of the providers that participated that were starting to adopt, they were still skeptical of AI. And even it was interesting to get to a definition of what does AI really mean? What does that mean in the imaging space? And so it was really interesting and of course fun from a patient standpoint, not just from the KLAS standpoint, to see that imaging is really being accelerated. So we saw a lot more, not only adoption, but we saw a lot of decisions that were being made around AI. We also were able to track what some of those organizations have done from when they went live. Also really awesome to hear that providers report the deployment was closer than ever for some of those that were either adding a vendor or adding a different algorithm for another area, or just making a decision for the first time. And then the depth of adoption expected to increase. I think that's a given. I think all of us assume that or would know that, but we definitely were able to see quite a jump in the past 2 years. It's interesting when we have our live interviews, one of the give backs, one of the things we always talk about with providers, at the end of the call, we ask, what can we share with you? What data are you looking for? If there's a report that we have that's live, of course, we're going to share that complimentary with our providers that participate. But we always want to know what can we work on and what data do you need to get in your hands? AI comes up quite a bit. It's probably no surprise. And when we ask a lot of providers, what do you need? What are you looking for? It almost feels like sometimes people need a start. Where do they start? How do they implement? How do they make a selection? So we actually asked one of the questions to all the participants were, what were some of the best practices? And we'll talk a little bit more about that today with our panelists. But it was interesting that a lot of people talked about just in the embedded AI into the workflow. And they also talked about bringing people together. There's a lot of different opinions and what does AI mean to different people. So that was something that a lot of organizations talked about. Also just taking ownership of the change management. What does that mean to the different people and the clinicians that are going to be working with the AI solutions? And then of course, what to look for when people are going to market and deciding on a vendor. So we'll talk a little bit about that as we go forward. It was also interesting that when we talked through our summit, we actually had a summit around enterprise imaging, which was a broader focus, not specific to AI. No surprise that AI kept coming up. And a lot of the providers said, we really need a partner. We know this will be in multiple solutions and in some cases, multiple vendors that will be working together. And really that partnership, we need to have availability. We need to have an aligned experience, of course, empowered sales consultants on the vendor side, and then understanding our vision and where we're trying to go. So just thought these takeaways would help as we move forward with our panelists. And we'll go ahead and turn that back over so we can get back to the panelists and going through some of the questions and talking through some of the best practices that they've seen within their organization. Okay, perfect. So thinking back to some of the pieces that we gathered from our data, would love to throw out to the panel. Knowing and understanding there's hundreds of vendors and AI is coming up quite a bit, would love to talk through how you're using AI at your organization. And I know we gave a formal introduction, but would love each of you to take a moment and just share how you're utilizing AI just to set up a foundation and a bit of a background as we go through some of the questions.
I'll let you start, Dr. Rosen.
Okay. Unmute. So thanks, everybody. So we have implemented 3 algorithms for Aidoc, the intracranial hemorrhage, the PE, and the C-spine fracture. And then we're hopefully going to be implementing the large vessel occlusion stroke algorithm pretty soon. And so the initial rollout was in the ED, and we did that for a few months. And then we rolled out the PE algorithm in chest, and then the C-spine fracture and the intracranial hemorrhage with our neuroradiologists.
Similar with us. We're an amalgamation of private practices that act as one practice. So we rolled it out to several different geographic areas, including our large teleradiology practice, which I'm a part of. And just like Max had mentioned, we first started using intracranial hemorrhage, PE algorithms, and really what in the ER setting that we typically do in teleradiology. And one of the things that, as you mentioned, there are hundreds of AI groups that we were surprised by was just the very seamless integration with our PAC system. I think that was a clear differentiator for us because we need it. And so many times, I don't know, Max, if you've had the same experience, but when you talk to the software engineers at an AI group, they almost don't realize that you need an interface, that you look at images on something else other than their software. So.
Yeah, our IT group was really impressed with the Aidoc team. The build and the integration and implementation was really like the most seamless IT thing that we've done. And there was just really good communication between the Aidoc group and our IT team. So that was a real plus for us. We had sort of decided we needed to start working with a vendor and made the decision to start with Aidoc, and had a really positive experience aside from the algorithms, but just the implementation and the nuts and bolts of getting this up and running.
Yeah, it was very clear, Monique, to us at Rad Partners that Aidoc had worked with radiologists before. Sometimes some of the AI groups you don't even think they might have even talked to a radiologist before. So that was very, very key differentiator for us, because the radiologists that use this needed to be seamlessly integrated. They don't have time. They're reading at night. They're reading emergent studies. They're held to, really pretty strict time criteria for things like stroke, which are life-threatening, imaging studies. They needed something completely seamless.
That's perfect. Thank you. Really, really helpful feedback. So it sounds like you would both agree, definitely the combination of when you're selecting, making sure a vendor will work with IT as well as deeply understanding the PACs or the other solutions involved, and then of course, understanding from the clinician's point of view. Okay, excellent. And then the other question we get asked quite a bit, and both of you shared your experience with me, so I thought that would be helpful in understanding. Several providers, when they're talking with us and asking questions, they say, what do we expect from an implementation? I know you both touched on it lightly, but would like to understand a little bit more, just kind of high level, what does the implementation look like? And a few of the questions that we get quite a bit is, what about workflow? That's obviously very, very important for the radiologist. That has to be seamless and a part of the already workflow. So would just love to know more about how did you set that up, and then talk a little bit about your workflow, and then if there was change management involved, how did that move into it?
I can start. So we started, as I said, just with our ED radiology group, because it's a very defined, group of about 12 people. And we started with the pop-up notifications. And we haven't yet integrated into our work list, but that would be the next stage. And I think initially it took the group a little bit of time to get used to seeing these pop-ups. We had some network issues where with the initial build, the pop-ups were sometimes they were very slow. And so the radiologist was reading the study and ready to sign off on it before the information from Aidoc came back. But we were able to troubleshoot and resolve that, and then get to the point where the pop-ups were coming in a very timely manner before somebody was ready to sign off on it. Another issue for us was whether or not we were going to let the residents and fellows use Aidoc. And as when we started, we've just kept it to the attendings because we didn't want the residents and the fellows to just rely on the algorithms. So that's something for educational or training programs, about how you begin to think about phasing that in. And for us, that's sort of like a part 2.
Yeah, I would agree with that. We also are not using it for triage right now. I can imagine that once we do, the integration would also be pretty seamless. We actually, definitely were even helped by the audible alert that pop-up has in its latest iteration, because anything you need, radiologists get so sidetracked, they're looking at the images, they may not notice things in their peripheral vision, et cetera, et cetera. So that was very key for us. I think one of the things that Dr. Rosen mentioned that I do agree with is that I personally have tested actually quite a number of AI vendors and different products in my workflow. And, just to give you a funny example, there was one product that gave such a beautiful evaluation of a stroke and did all sorts of amazing graphs and cool things and max. What would happen is it took so long for the images to go to the server and come back and get analyzed that it was like 20 minutes. And by that time, the radiologist had already finished the case 10 minutes ago. And so one of the things that I am it's very, very clear that Aidoc has worked with a lot of radiologists. Their speed of interpretation is quite quick, so that as soon as you open the case, a few seconds after that, I get an interpretation. So that's definitely an important thing for AI vendors to keep in mind, that radiologists, we can't afford 6-7 minutes later for a pop-up to come up.
Another thing about getting from a little implementation, but also into use case, because every hospital or system has the population of the patients is going to be a little bit different, and so we worked with Aidoc and took about 6 months of our data for head CTs and PE studies, and then ran that through their algorithms to see what the false positive, false negative, all the different combinations were. And that was really valuable for us to see, in the cases that we thought, Aidoc was overcalling things. And then we've also worked with them to use natural language processing to read our reports and see if there was a case that Aidoc would have flagged that we did not. So we've really been able to, for our specific practice, get the true sensitivity and specificity of the algorithm, with our group of radiologists. And that's something that I thought was very important, that Aidoc committed to do that. It wasn't, like an add-on. It was just, we are going to show you how we perform in your environment.
Yeah, totally agree. Similar experience. We had to have valid data because, first of all, the ability for a radiologist to trust an algorithm, it better be pretty accurate. I mean, like 90% is not good enough. You need to have extremely high sensitivity because the radiologist's trust is very fickle because they need the results to be accurate. And I think that what you said was actually very true of the experience we had. I could actually see that the algorithm was getting better over time, which is the definition of artificial intelligence. It learns from past mistakes. And sometimes you don't see that with things that are termed AI and may not be totally AI. AI gets better with time. So that we definitely see that happening. In the early use cases, Max, I would see maybe sometimes a inferior pulmonary vein be confused with a pulmonary artery branch, and it just doesn't happen anymore. So, you know, that's very, very gratifying to see that kind of change.
One of the questions that comes up quite a bit, and you both touched on it, is what happens when there is a discrepancy? Is there a committee? What's the process? And we get that from a lot of providers. So would love to understand, you obviously know that's going to happen, so you brought that up, and especially in the beginning. How did you determine, or what was the process or the committee, and how did you move forward with that? Just so that, like you said, the radiologists have to trust it. Any best practices or anything that you did, or maybe something you worked with Aidoc to move that forward faster?
I can tell you from our side, communication was very important, so that the RADs need to, you know, understand that there is this software, but it's not gonna, you know, it's not gonna replace them or anything else. We didn't want them dictating, this was read by AI software, et cetera, et cetera. So, you know, that training piece was key, and open communication at all times. I think that I'll speak for my teleradiology practice in that every single rad in there has my cell phone. They're able to get a hold of me, and they're able to get a hold of someone at all times if there is a discrepancy. So I think that's really the best way we approach those things.
So setting expectations at the organization level, and then
100%.
an understanding.
Yeah.
Okay, very, very helpful. Yes, training came up quite a bit, and we had several people that said yes, it's training from the vendor, but it's also training within the provider organization, and having that be a trust that someone can ask about a discrepancy, and then people work through that together. So that's really helpful. Thank you.
Yeah, I can talk a little bit about how we've been handling these issues. And I think the first issue is when you take a data set and run it through the algorithm and find what you feel is a true miss, you know, what do you do with that? And the way we decided to handle that was as if we were doing, you know, peer review, and, you know, we're double reading a study that had been brought to our attention, you know, from a clinician, from a patient, from a conference, whatever. This just happened to be brought to our attention from the algorithm. And then we notified the referring provider of the discrepancy and issued an addendum.
Yep, that's mirrors our workflow as well.
In the real time, you know, at the end of the day, it's the radiologist's decision how they're going to read a study. And the algorithms are a piece the same way as if you were reading, you know, with a really good resident who maybe picks up something that, you know, that you're missing. The thing that we don't have an answer for is, you know, are we keeping all of the Aidoc annotations as part of the medical record? And if something was found to be missed, you know, is the Aidoc finding discoverable? How does that fit into the legal system? And our head of QA, Steve Bache, has done a lot of work, you know, regionally. He and Jen Broder from the Leahy Clinic created something called the Mass Radiology Quality Consortium, and it's become sort of a subgroup of the Mass Radiology Society. And I think one of the things on the agenda for next fall will be to start having a regional discussion about how we really incorporate AI into the whole, you know, QA process in radiology departments. And hopefully the ACR would take that up sort of on a national front.
Yeah, that's fantastic. I mean, there's so many unanswered questions about exactly what Dr. Rosen mentioned, medical, legal, this, that. That's great. We ourselves are moving to have a patient safety organization. One of the other things is we're moving rapidly to a peer learning system. And there's a role for that with AI, because in peer learning, the whole sense is that, you know, misses or discrepancies, they should not be a punitive thing. They should be a learning thing. They should not be something, there's so much shame and issues with a discrepancy right now. We want to remove that from the process so that you can actually be sharing these cases openly and learning from your mistakes, which is the goal.
And we've also done away with the peer review and have moved to peer learning. And I think, again, this is a great way of flagging cases, which to go through the peer learning process.
Yep.
One of the questions that also comes up, and we have people, usually when people are looking in, when organizations are looking in or trying to expand AI, they ask us, how is that communicated to the patient? In some ways, some people could be really excited about hearing AI. In other cases, if it's not well communicated, that could make someone nervous. Curious how your team and your organization has tackled that, and if you have found best practices or pros and cons either way of just letting the patient know or getting the word out for patients.
I know we don't formally tell patients, oh, if you come in with an I- head CT, an algorithm's going to be, we're going to be running this algorithm. But our marketing and communications department of the hospital has been really interested in this. And my sense is that there's a lot of interest in the community in going to a healthcare institution which is using these algorithms, not so much that computers are going to be, blindly reading their studies, but that the institution, I think it reflects the institution's commitment to quality, to keeping up with the latest technology, and having another level of a process to ensure that things are read correctly.
Yep, I agree. It can be very reassuring. I don't think it's anybody or any AI product is ready yet, for a patient to actually hear about it, because they might not understand that it's more of a tool for the radiologist. In the end, the buck stops with the radiologist. The radiologist is going to decide if something's artifactual, real, not real. So I think we're still a ways away from that yet, but I definitely think that you see hospital systems, even in a small town, one will say we have a Da Vinci robot, and the other will say we have a Da Vinci robot too. So this will probably follow along the same path, I think.
Okay, super helpful. Thank you. And then this question is a fun one. We actually asked this as part of our study, and I feel like we still get asked this quite a bit. Who pays for AI? That it's just interesting that comes up quite a bit. And then how do you measure an ROI? And a lot of people that were early adopters were telling us there's definitely an ROI, but it's a little bit tricky to measure. Would love to get your take on that. And I'm sure you get asked that quite a bit.
Yep, I can start. So when AI was first starting, I think it keeps popping up because for a long time, nobody knew and nobody would give a great answer. And so, it was a question, is the insurance companies going to pay for them? Is the radiology group going to pay for it itself? Is the health system going to pay for it? Or are the PACS vendors going to pay for it? It was like one of those four, who may pay for it? I think in a certain circumstance, you may have anyone who wants to differentiate themselves. A health system wants to define itself differently from its competitor. They may see the ROI there. A PACS system may integrate AI algorithms and say, hey, we're better than X because of this. But definitely a RAD group might even say, we want to differentiate ourselves, but we want to actually be a higher quality group and be more efficient with AI. The trouble I see is at the insurer level. That's going to take some time for an insurance group or payer, third-party payer, or even a government payer to say, you're using AI, so we'll give you X, Y, or Z benefit from it. I think that we're still far away from there, but the other three are absolute possibilities.
And so, yeah, I agree. In our case, we took the route of going through our IT steering committee to get funding for the product, and when they have sort of a standard template, and you have to decide whether you're going to say that there are hard benefits or soft benefits. And I really avoided going down the route of the hard benefits. I know there's data out there that shows increased turnaround time for radiologists and even decreased length of stay. But I felt that there's so many variables that go into turnaround time and length of stay that to make that the basis for the argument that the hospital should fund this, that wasn't really going to be successful. So I actually, the points that I made were, first of all, on the quality and safety, and that even if we can prevent, one missed PE or one missed intracranial hemorrhage, just the outcome for the patient is worth it, let alone, frankly, the liability cost of a missed case like that. The other selling point, which I think rang true with a lot of people, was that AI is here to stay, and if we want to be a competitive place to attract, faculty to work and also to train residents, that we needed to have an exposure to AI, for the faculty and the trainees. And then there were a few specific use cases which Aidoc doesn't have in production now, but my argument was we need to start with a platform. These guys are really good to work with. They're going to have these algorithms in the future. And the two algorithms that I think are really interesting for us are things like, pneumothorax, rib fractures, misplaced lines, free air, all the plain film stuff.
Oh, yeah.
We own 3 community hospitals, and I'm under a lot of pressure to read all of the inpatient exams they're staffed, which I can do until 5 p.m., but after 5, it would be very expensive for me to hire enough faculty to do that. So we're hoping that when those algorithms come online, we'll be able to, really, real-time triage all the plain films from the community hospitals and be able to do stat reads on the ones that are flagged. The other selling point was the COVID algorithms, which again, are not ready yet, but when they are, to be able to identify patients who have findings suspected of COVID on CT, and then immediately, shut down the scanner and clean it before you put other patients, on the scanner. Because in the height of COVID, we had lots of issues, and we spent a lot of time dealing with, a patient who was found to have COVID, an hour after they left the scanner, and then, figuring out all the contact tracing and all the anxiety for the technologists and the staff. So I think that's another real benefit for us.
I agree. I actually, have approached the what is the benefit of AI question. As a teleradiologist, we have to read from all different sites. And some of those sites, they don't put the information in the same place, right? So as an example, the history might be in a scanned paperwork, or it might be in the place that it should be, or it might be in the technologist notes. It might be in one of many places, or it might not be there at all. Our point was that if you have the workflow is so difficult already for a radiologist. If you have AI as a tool, then it's not about, oh, I can read faster, but hey, I can spend the time it takes to do X, Y, and Z to make sure that the patient gets the most time, that I get the most time on the images and do the right interpretation, because the AI part of it is eliminating some of the bogus stuff for us. So I think that's what people don't realize is, 20 years after my training, I feel like there's even more stuff in the workflow that has to be paid attention to, not easier,
Yeah, that's great. I was going to ask you, and then you jumped into the COVID. So thank you so much. That was really helpful. Curious what you feel, or what has changed, or anything that you've changed post-COVID with AI or using the algorithms.
We haven't changed anything per se with AI related, to COVID. I mean, obviously with the thromboembolic component of COVID, which people are just beginning to understand, the ability to find, small PEs on, on a wider range of studies, and also for stroke. I think those are going to be two areas which, naturally fit, because it seems like those are going to be manifestations of COVID that we're going to have to be, really attuned to.
Definitely agree. It's a radiologist actually, now that it's been several months into the pandemic, you can see that the radiologist can clearly identify COVID. But, the large vessel occlusions and things like that, that's where AI is going to really help. And I think the point about identifying it fast so that, a CT tech may not have to do all this contact tracing, that's a brilliant point, because that's where knowing about something faster is just so indelible. It may not be more accurate, but knowing about it faster than usual is a big help to the entire healthcare system. It's about safety of the people working there as well.
Mm-hmm. Mm-hmm. Really, really helpful. And curious if you could talk a little bit about productivity, some of the areas where you see increased physician productivity or from the radiologists.
I could start. So many scans. You think that every scan is performed perfectly well, but we have so many scans that have a little bit of motion, or the positioning is not quite right, or the patient might be breathing a little bit, or there's some pathology that's obscuring the little pulmonary arteries, et cetera, et cetera. That's really a place where AI can help with productivity of radiologists, because I can look and look and look and look at little vessels that are tough to see because of artifact. But if AI can help me by saying, hey, Samir, I've looked already, there's nothing in that stuff, it can definitely make your threshold as a radiologist to stop looking and go ahead and sign the report much better. I don't know what you feel about that, Max, but.
Yeah, we haven't really looked at the impact on productivity. I think it might be more of an issue in a sort of a for-profit teleradiology business than in an academic practice, although obviously productivity is important, but I don't think we're under the same pressures that other types of practices, might be.
Mm-hmm. No, I think that's fair, but again, I think there's so many factors. My main goal, and I know the colleagues that I work with, our main goal is to just free up the radiologist to, we don't even care about turnaround times with AI, et cetera. We just want them to be able to do a better job, like to be able to say, I've got 30 tasks to do. I may have to cut corners on 4 or 5 of them. We'd rather do all those 30 tasks, look for the history, look for everything, and let AI shave some time off of the, going back and forth over whether there's a PE or not. And then you have extra time to do those other tasks.
Yeah, perfect. I think that was all my questions. I know there were some questions coming in online, so I'll turn it back over to the Aidoc team and for the questions that came in online. Anything that you would like to share in closing that you think we didn't ask that would be really helpful for the attendees?
I think that there, as Samir said, there are so many vendors out there, with AI algorithms and products. And I think for us, we started early on thinking we could work with everybody. And that of course doesn't work. And so we decided we needed to choose one vendor, start working with them. And if it worked out, great, we made the right decision. And if it didn't work out, we would have learned a lot. We probably would not have wasted a lot of time because we were just focusing on one vendor, and then we could move on and we'd be able to ask different questions, having learned our mistakes. And so, so far we've been very happy that, Aidoc was the company that we've started, to work with. Other places might have a different strategy where they do try to work with 5 or 10 different vendors, but we just don't have the bandwidth to be able, to do that.
Yeah, we actually have the bandwidth, and we've done that. We have 1,600 radiologists, large geographic, national scale, And what I'll say will kind of mirror what Dr. Rosen experienced is that you have to look at the culture of the group, the AI group. I think that tells you a lot. Like, you can work with a lot of these vendors, but they need to have a culture of healthcare. They need to have a culture that has worked with not only the PACS systems, not only the technology to route cases from one place to the other, but they have to work with radiologists. Radiology and IT, sometimes I think they're on completely opposite wavelengths. And so, you know, whatever group that you end up working with, they have to have the right culture. And you'll know instantly, and I think we knew pretty quickly that Aidoc had the right culture on board.
That's really good. Thank you so much. Thank you for the feedback. I'll go ahead and turn it over to you.
Thank you. So thank you both, all three of you, Monique and Dr. Rosen and Dr. Shah. It was an amazing panel. I'm going to open this up to additional questions. I've been responding throughout, but there are a few questions, so I'm going to read them out, and then I'm just going to let whoever wants to answer. There is a question about the implementation, a question of how long did it take, I guess from initial interaction to actual go live, and maybe a bit about the user experience. So maybe either Dr. Rosen or Dr. Shah, either or both of you take that.
Do you want
I'll start. I'll just say really quickly that the implementation time was much faster than I ever thought it would be, and that goes completely to, you know, Aidoc's software engineers, because working with hospitals can be tough. Working with a hospital system. So, you know, one thing is Rad Partners, we have our own IT group. So I think both of them were pretty motivated to work fast. So that lag time didn't exist. I do want to hear from Dr. Rosen about that, because I know hospital IT has sometimes their own agenda, own timeline.
Yeah, so I think we're up and running with the proof of concept server, maybe in about 3 months. It was a while ago now. And then, you know, over time, we fixed all the bugs, and then built out, you know, more modules of the implementation. But we were able to really be up and running, you know, and test in 3 months. And another really nice thing about our relationship with Aidoc is we have an every other week call where they give us our data, you know, how many users, how many algorithms, how many studies did we run, how many were positive, how many were negative. And it really feels like a partnership, and there's a really good dialogue. And, you know, we've actually gotten to be like Zoom buddies, you know, through that interaction. And I haven't had that level of a team effort with many other vendors.
Yeah, actually, if I see a great save by Aidoc, first I email it to our RADs or our leadership team. Next thing I do is I email it to the Aidoc leadership team. And they both get excited, you know? It's really a nice thing to see. I think that's very true, that if you're dealing with, if it's a vendor relationship, that they're selling you a product and then they're going to be gone, it's not the right fit, because it does need constant interaction to really see how your statistics are going. If there's a problem, you know, if something's changed, that's the key thing. You don't want to implement something and just assume that it's working fine. You have to constantly be on top of things, and we've had a good experience that way.
And I think because this is, you know, a completely new industry, this isn't sort of like you buy it off the shelf. It's not like buying an iPhone, you know, where you go, you pick it up, you plug it in, you load some apps, and then, you know, you keep it until you drop it or the battery runs out. And so I think having an AI vendor who you really are partnering with makes the whole experience, you know, that much better.
No question.
Thank you. There's another question maybe, I think you mentioned, or you both may have mentioned, the sort of proof of concept, which was the initial interaction. So the question here is, in retrospect, was there anything that you would have done differently now that you've navigated through the process? Maybe that's a question again to both of you. Both of you have done that sort of initial proof of concept.
It's hard to say you'll do something differently because, as Dr. Rosen said, it's so new, right? It's not like we're testing a new mouse, you know, and this are the steps you have to follow. I think, Ariella, would you not agree that Aidoc learns from radiologists just like, you know,
Absolutely.
we learn from you guys? Yeah, it's a two-way street right now. Even, you know, Dr. Rosen, you had mentioned trainees and kind of a very smart move was to, you know, kind of shield them. In the future, though, I think we may involve them because they're the ones that are going to actually say, they're the ones that are going to use more AI products than I do in my career. You know, this is going to be with them for the next 20, 30 years. And so I think they're going to be very sharp and they're going to learn a lot about sensitivity, specificity, false positive, true positive. They're going to learn a lot about that, and they're going to grow with that technology. They're going to learn what to trust, what not to trust.
Yeah, and I don't think there's really anything that we would have done different in the implementation. And I completely agree that we have to involve, you know, residents in this. It would be like if all the attendings were reading on PACS and you were having the residents reading, you know, hard copy films. I mean, that doesn't work. But I think this is so new, and you know, for the faculty to really begin to really understand how it's affecting their practice before we start engaging the residents. But I know when, you know, during interview season last year, one of the first things that most of the resident applicants asked us was, are you guys using any AI? You know, how is it in the practice? Are we going to get exposed to it? So it's clearly on the residents' radar.
It is. And I can say probably the answer would have been no for most of them, you know, because not a lot of places are using AI. It's hard to find an actual implementation. It's absolutely very easy to say we're looking at AI or this or that, but to actually say you're using it, very few right now.
And so maybe a follow-up question to that is, what was the driving force behind not waiting for both of you, I guess, right? As you said, not many are using AI. So what, in the end, for each one of your sites was the driving force to decide to go forward?
For us, it was, you know, we have to be the leader in the space. And we don't want to follow anybody's lead on it or hear about what anybody else is doing. We want to be the first. So that was our impetus.
And I think for us, you know, anything that could possibly, you know, improve our performance and provide better care for patients is really attractive. And then also to have something which trainees are looking for. And, you know, I think if you ask people, do you think AI is going to go away? Yes or no? And probably, you know, the answer is no. So if it's not going to go away, then you're better off starting to figure out how to use it as soon as possible.
Agreed. Monique, any thoughts or any sort of padding, I guess the notes from your end, I guess given the research that you run and given sort of the interviews that you've had with, I guess, not just these two great gentlemen, but in general?
No, I love that that they both mentioned there, and you mentioned there's not a lot of live sites. So one thing we get beat up on a little bit, and lovingly beat up, is providers are like, where's the performance report? Why don't you have more data? And we keep saying, well, implement so we can call you and bug you and get data. So that's why we have the two perception studies of purchasing plans and implementation and best practices. And of course, we hope to roll out more data on live sites. But it is interesting that sometimes providers feel like they're behind, and they're definitely not behind, but at the same time, there is a lot of movement. As your team knows, you're very busy implementing, and there are a lot of decisions being made. So it's fun for us to watch it, and it's really fun to work with the two gentlemen and hear what they're doing. It's nice to be on the class side, but of course as a patient. So all of us are getting older. So thank you all for what you're doing, and it will definitely benefit all of us.
So thank you very much. Any parting thoughts before we let everyone go on with their day? Any final words?
I appreciate being here with Monique and Dr. Rosen. It was a pleasure. It was great panelists.
Actually, if you don't mind, I just saw a comment come in, and it's one that we get asked quite a bit. So if you don't mind me stealing a couple more minutes of your time, the question was, were there any radiologists who pushed back on AI but now love it? So I'm first going to answer from a few of the providers that even a few years ago said there's just no way in hell and we're not going to do this. And as they start looking, and a few of them start adopting some algorithms, they're the ones calling me and getting really excited. So I will say, from my point of view, it's been fun to see that transition. And now we'll turn it over to Dr. Shah and Dr. Rosen, the experts.
We had one of those, and I think I ended up sending Elad the email. Completely turned this person around, you know, from biggest naysayer about AI to a big raving fan.
Yeah, I think there were like 3 different groups with us and how people approached it. And I think uniformly the ED radiology group was very accepting of it. It's like, wow, this could really help us. The chest group was like, yeah, this can be helpful. We're open to it. And is it going to help us sort of read faster and hopefully not miss things. In the neuroradiology group, the general consensus was, well, I'm like a CAQ'd neuroradiologist. I don't need the algorithm. Those people in the ED, they might need it, but I don't need it. And then after a few months, I think the general tone changed to, gee, you know, every now and then it's helpful, especially if the study has a lot of motion or it's poor quality. So if it's a really good study, it's not helping me, but there are cases where it will help me. And to me, I took that as a little bit of an admission that, yeah, we're finding it helpful.
Yeah,
that's a little bit of an admission. that's a lot to say. So thank you very, very much, Dr. Rosen, Dr. Shah, Monique. I thoroughly enjoyed this. I appreciate your time, and I look forward to doing similar sessions with you all in the future. So I wish you all a good afternoon, a good evening, wherever you all are, and see you again soon.
Thanks a lot.
Thank you so much. Thank you. Bye-bye.